Dr. Malay, sir. Can you hear me?
Saurah?
Can you hear me, sir?
Yeah.
Yeah. So thanks to Dr. Malay and Dr. Ruchika and Team KOS for this opportunity. And I'll be showing a couple of intravitreal injections. One of them intravitreal aflibercept and the other one an intravitreal Ozurdex implant. And nowadays these injections and implants are the bread and butter of the retina surgeon for a medical retina practice. And Dr. Abhijat will take you through the cases that we have today. The first one is for the intravitreal aflibercept.
Okay, so now we'll come to the live intravitreal injections part, and this will be done by Dr. Saurah Luthra, who's the director of the Vitriol Retina and the UVA services at the Drishti Institute. So the first case is a 76 years old female with complaints of gradually progressive diminution of vision in the right eye since 3 years. Her best corrected visual acuity in both eyes is 6/36 with no improvement on pinhole, and her intraocular pressures are within normal limits. So she has a history of multiple intravitreal injections in both eyes in the past over 3 years. So this is the Optos ultra wide field imaging of her right eye, which is showing that there is some scarring CNVM formation in the macular part, and this can also be seen on the autofluorescent imaging of the same. So this is the colored fundus photo taken on the Topcon machine, and this shows that there is some activity going on in this wet ARMD, showing the scarring CNVM and a hemorrhagic part also. So this is the angiography image, which shows that yes, there is some CNVM formation when we see the choriocapillaris layer of this, and we can very clearly notice that there is all the three components, which is the IRF, the SRF, and even the fluid is below the RPE level. And this is the these are the OCT scans. These are the OCT scans showing the grid raster, the radial line part, and we can again observe that there is some CNVM formation which is scarring, and there's active fluid which is intraretinal, subretinal, and even below the RPE at some places. And the patient has a waxing and waning kind of pattern whenever she is injected, and till the point where the effect of the drug lasts, her swelling goes down. But as soon as the effect goes off, the swelling comes back again, and then she is again planned for another injection. So the treatment plan for this patient as of now is right eye intravitreal aflibercept under topical anesthesia with a dose of 2 milligrams per 0.05 ml. The second case is a 65 years old male. Yeah, sure. We can inject the first case and then we'll go back.
Yeah, so the patient has been treated and raped already, and now I will show you how we will load the injection of aflibercept. And I would request Mr. Lakus to please point his camera so we can show how we are going to load the injection. So we are using a BD 1 cc syringe, and we use a spike or a needle with a filter for withdrawing the injection from the vial. And we have two cotton swab sticks which are dipped in spirit, which we clean the vial, the rubber bung part and the metal part on the side twice. So once and the second time around. So these are sterile swab sticks, and then we dry it off to take off the excess alcohol from there. And then with the spike on the 1 cc syringe, we pierce the rubber bung right in the center, and then my assistant will hold it inwards so that I can see the level of the injection inside and get the needle inside that fluid or the injection and gradually withdraw the needle as I withdraw the injection into the 1 cc syringe through the spike filter needle. So I managed to get almost the entire volume of the injection inside my 1 cc syringe. Now I take off the filter spike needle, and then I will just attach a 30 gauge needle to this, which we will be using for injection. Now I'll discard the air from this and make sure that the injection is ready to be used. So is my microscope field visible there, sir?
Yes, Dr. Saurabh, we can see.
Okay, sir.
We have put Peter in.
Can we switch on the Varion? We don't really need the Varion. Thank you. So first, the assistant has already put betadine on the lid. So I just wash that off. And then ऊपर देखिए माजी, इधर इस तरफ सिर नहीं हिलाना है आपको, इस तरफ ऊपर देखिए, हाँ, और सिर नहीं हिलाना है माँ. I usually prefer the infratemporal quadrant for injection, and it's a phakic eye. I mean, sorry, it's a pseudophakic eye, so I can use 3 millimeter also. So 3 millimeter is the preferred, marking for me with the calipers. And then इधर ही देखते रहे माजी, बस अब हिलाएंगे नहीं, बिल्कुल ऐसे ही देखते रहिए, अब हिलाएंगे नहीं. And then with the 30 gauge needle, I will just enter at 3 millimeters. And once I'm in, I don't really need to see the needle inside, because with more than about 2/3 of the needle in, I know that I'm inside the vitreous cavity. And then I will inject 0.05 ml. And then with a cotton tipped applicator, I will just, you will see this movement, that it just blocks the extrusion of drug or the reflux of drug from inside the vitreous cavity, and I keep it plugged immediately for at least 30 seconds, 30 to 45 seconds. And this prevents, any extrusion of drug. You can see that there is no extrusion of drug from the site of injection. And then antibiotic drops are instilled.
Very clean, Dr. Saurabh. I think we have got two retina guys standing here, Dr. Manish and Dr. Mohit. So I will have comments from each. Dr. Manish.
So the first injection is done, and I hope it was clear.
So Dr. Manish is a retina surgeon here in Kanpur. Dr. Saurabh.
Yeah, hi Dr. Manish. I know that he's doing very good work there. I keep seeing on the webinars.
Thank you so much, sir. And it was very nice to see the overall procedure. So my simple first question is pre and post antibiotic. What you prefer and for how long you prefer to giving after intravitreal injection?
Yeah, so when I was in the States and we used to give these intravitreal injections, we never, the patient used to just walk in into the OPD and give the, I mean, get the injection and just walk out without any need for any antibiotics, and sometimes to the extent that even topical antibiotics were not used. But here in India, we have to be more diligent, and we do it in the OT rather than in the outpatient department. And we do give topical antibiotics for 5 days at least, 5 to 10 days. And in those cases which are like diabetics, we also prefer to give an oral antibiotic cover for starting 1 day before and going up 3 days after the injection. So in diabetic patients and in high risk cases, we are more aggressive as far as the treatment with antibiotics is concerned.
And what about the putting pads? You put pads in every cases or?
Yeah, so we do patch all our cases because again, there is a tendency for patients with in some centers they do give dark glasses, but there is a tendency of the patient to rub the eyes and all, and we don't want that. So we do give a patch for a couple of hours, and after a couple of hours the patient takes off the patch and starts the drops, and we do see the patient the next day on the first post-op day just to make sure that there is no inflammation and no sign of infection in the eye.
Thank you, sir. Thank you so much.
Thank you.
Good morning, sir. Mohit here. I just want to know one thing that these days we are getting pre-fabricated Vitriol swabs from Glitch. No financial interest in that. That those beta swabs what we are getting. Any experience of using those for preparing the eye?
Yeah, so I think Dr. Gaurav has been using these Kilich swabs. In fact, we have them in the OT right now, but I'm just using those standard, swab sticks with the which I dip in betadine, and we can use the pre-fabricated ones as well.
Okay. And do you routinely dilate the pupil before giving injection?
Yes, we do dilate the pupil. The reason is that especially you'll see in my next case that when I give the Ozurdex implant, I like to see the tip of the implant inside and the implant extruding out into the vitreous cavity. For intravitreal injections, we just dilate, but it's not a necessity. But yes, we do prefer, because sometimes if you get high pressure for some reason, then we would like to see for any pulsations of the central retinal artery and do a paracentesis if required. So that is the only reason why we like to have the patient dilated at the time of intravitreal injection.
Okay, thanks a lot.
Thank you. So I think we have the second case now, which is an Ozurdex implant, and Dr. Abhijat will take you through the case history.